Hello, I'm Mrinalini Dey, and I'm an academic rheumatology trainee based in Liverpool in the UK, and I'm reporting from ACR 2020 for Rheum Now. Today, I'm delighted to be joined by Dr. James Galloway, who is a senior lecturer and honorary consultant in rheumatology at the Centre for Rheumatic Diseases in King's College London. And he has an interest in infection in rheumatic diseases, and it's this that we will be discussing today. So thank you for joining me, Dr. Galloway. Firstly, can you tell us a little bit about how over the last year COVID-19 has changed your research and clinical practices?
Well, yes. I mean, the impact has been phenomenal, I think, for all of us. I recall doing a journal club, I think in January, where we talked about things that were going to be on our horizon this year, and came up with vaping and vaping-associated lung disease, and this new virus that was emerging in China. And I think we spent most of the time talking about the EVALI, the vaping-associated lung disease. And obviously we're then within a matter of weeks after that, overwhelmed by the pandemic. My research team has almost entirely got redeployed from doing our usual rheumatic disease research to doing COVID-19 research, although there's a lot of synergy there because, of course, we've set up one of the UK national platform trials called the Tactic trial, where we are looking at immune modulation in COVID. And so there's sort of an expertise from the rheumatic disease field that has come to that. And of course, and from an academic perspective, my research interest is epidemiology. And so there's a synergy there that we've been able to adapt and been doing epidemiology work around COVID-19.
Fine, great. And something which you alluded to just now is the interplay between rheumatology and infectious diseases. Could you just expand a little bit on that further, and maybe if you could tell us about any abstracts that particularly caught your attention with regards to that at ACR?
Yeah, so I think there's a long-standing interest between the overlap between rheumatic disease and infection, because so many of our treatments alter the body's immune system and potentially alter people's susceptibility to infection. Also, I think that the nature of having an autoimmune disease changes our immunological response to infectious insults. There is an ACR abstract committee group that looks at infection and autoimmune disease, which Cassie Calabrese and I oversee, and there have been some. I mean, normally it's a relatively niche area in terms of submitted abstracts, and obviously this year there's been a huge wealth of some really great research come through. I flag? There's a few that I think are really interesting. Yeah. The first one, and it's easy to remember, it's abstract number 1, Jaz Singh, who has presented the data from the Veteran Affairs database, just looking at the describing the impact of the pandemic on care. One thing, and it's a really great abstract they put together. One thing that struck out to me was the fact about medication shortage. They highlighted that a third of respondents to the work they'd done highlighted medication shortage as being an issue during the pandemic, because of course we saw this massive interest in drugs like hydroxychloroquine for being repurposed for treatment of COVID or prevention of COVID, rightly or wrongly. The second I wanted to flag, and this is a slightly it's not self-promotion, but there was on Friday afternoon a oral presentation which I moderated on infection rheumatic disease, and there were some really great abstracts in there, and I don't want to say that anyone was better than the other, but the first abstract was by Rachel Flood from Dublin, looking at a cohort of people who had been admitted with COVID, who'd had COVID. They had community data on COVID and hospital data, and they looked at whether or not being on biologics or being on immune modulation altered the chance of getting a severe outcome or dying from COVID. Like we're seeing across the board, there appears to be some protective effect of being on immune modulators if you develop COVID in the community. They spotted something quite novel, though, that I hadn't seen reported by anyone else, which was nosocomial COVID appeared different. So people with autoimmune rheumatic disease who acquired nosocomial COVID, acquired COVID-19 diagnosis whilst an inpatient, had worse outcomes. And that was a very interesting observation. I'd encourage people to look at that abstract. And then the final one, and so that abstract number was 0454. And the final abstract is one of the late breakers, so it's easy to find, and under the name Mark Yates. And that was a very nice piece of work. So not in that session. It was looking at shielding behavior and whether people with autoimmune rheumatic diseases shield. And what's really interesting, I think, when you look at the data, multiple data sets, the registries and other data sets that have suggested people with autoimmune rheumatic disease on biologics or on targeted therapies may be less likely to develop a severe course of COVID. However, one of the great confounders in this is being exposed, how many of them were actually exposed to COVID. And what Mark Yates's work does is it's large international, it's a global survey looking at shielding behavior, showing that people on biologics compared to other people with autoimmune rheumatic diseases were much more likely to adopt this behavior where they were, in the UK we use the term shielding, it's not used globally, but they were basically taking extra caution around their exposure to COVID. So it's possible that some of the potential protective effect of the drugs may be behavior related. Really interesting abstracts.
Great, thank you. And actually, the infection-related rheumatic disease oral session yesterday was really interesting. I'd encourage people to go back and watch that on demand if they can. And it's interesting what you say about the availability of drugs globally as well. I think I saw a poster in the infection session on drug availability from the AFLAR group. So certainly there seems to be a lot of regional variation in that. It's quite interesting to see, but I guess that's the beauty of ACR, where you get all of this combination of global information, so you can compare local practices with what's going on worldwide. So thank you very much, Dr. Galloway, for joining us today. Don't forget, if you want to be kept updated during ACR 2020, you can follow me at Dr. Mrinalini Dey on Twitter, or you can follow the Rheum Now Twitter feed. Thank you very much for watching.